The Great Stagnation, Decoding the Geometry of Relief. The modern toilet is an ergonomic disaster. By forcing the human body into an unnatural right angle, civilization has inadvertently choked our internal plumbing, turning a seamless biological function into a daily struggle against physics. This is not merely a matter of discomfort, it is a critical investigation into the mechanics of the pelvic floor and the silent crisis of chronic retention. We are fighting millions of years of evolution with flawed furniture. It is time to realign the anal-rectal angle and eliminate the resistance. The journey to total evacuation begins by returning to the primal stance that nature intended.
The squat position, full squat, the ancestral geometry of release. To understand the profound physiological necessity of the full squat, one must first deconstruct the arrogance of modern plumbing. For the vast majority of human history, spanning hundreds of thousands of years of evolution, the act of defecation was performed in a deep squat. This was not merely a matter of convenience or a lack of furniture. It was a biological imperative dictated by the architecture of the human pelvis. The body was designed to eliminate waste in this specific configuration, a posture where the thighs are pressed against the abdomen, the heels are planted firmly on the ground, and the center of gravity is lowered to the earth. The modern seated toilet, a relatively recent invention in the timeline of our species, represents a catastrophic ergonomic error that has fundamentally disrupted this natural process. When we sit at a 90-degree angle, we are effectively fighting our own anatomy, creating a mechanical obstruction that turns a passive release into a high-pressure struggle. The full squat is not an alternative method, it is the factory setting of the human machine, a position that unlocks the pelvic floor and aligns the internal piping for frictionless evacuation. The core of this anatomical puzzle lies in a specific muscle known as the puborectalis. This U-shaped sling of muscle originates from the pubic bone and wraps around the rectum, creating a crucial kink in the bowel. In a standing or sitting position, the puborectalis remains taut, pulling the rectum forward to create what is known as the anorectal angle. This angle, typically measuring around 90 degrees when sitting, acts as a continence mechanism, a safety valve that prevents accidental discharge while we are walking, standing, or sitting in social situations. It is a biological chokehold designed to keep stool in. However, when we sit on a standard Western toilet, this muscle does not fully relax. The chokehold remains partially engaged. The user is forced to push against the resistance of their own musculature, straining to bypass a kink that nature intended to be there only when retention was required. This creates a paradoxical situation where the brain signals the need to evacuate, but the body's mechanical gatekeeper remains in hold mode. The full squat fundamentally alters this geometry. As the hips descend below the knees and the thighs press against the torso, the pelvis tilts.
And the tension in the puborectalis muscle is released completely. The muscle goes slack, allowing the rectum to straighten out. The anorectal angle widens from 90 degrees to a much straighter 130 degrees or more. In this alignment, the rectum becomes a straight chute, a vertical corridor that allows gravity to do the heavy lifting. The kink is unkinked. The difference in efficiency is stark. In a squat, the pressure required to evacuate is significantly reduced, often rendering the Valsalva maneuver, the act of holding one's breath and bearing down, entirely unnecessary. This is the critical distinction. Sitting requires expulsion through force. Squatting allows for expulsion through relaxation. The deep squat transforms defecation from a pressurized event into a passive release, minimizing the stress placed on the intricate network of veins and tissues surrounding the anal canal. The historical context of the squat reveals a sharp divide between the industrialized West and the rest of the world, a divergence that correlates disturbingly with the rise of colorectal disorders. For millennia, the squat was universal. From the open fields of the Paleolithic in the Middle East, the squatting posture was the only posture. The introduction of the seated toilet, often attributed to the development of the water closet in late 16th century England, but not popularized until the Victorian era, was driven by a desire for dignity and separation from the filth of the act, rather than by medical insight. The aristocracy wished to sit as if on a throne, elevating themselves above the primal nature of excretion. This shift in posture was a triumph of plumbing engineering, but a disaster for human physiology. As the porcelain throne spread with British imperialism and Western industrialization, so too did the incidence of constipation, hemorrhoids, and diverticulitis. Epidemiologists have long noted that these ailments are virtually non-existent in rural populations in developing nations where traditional squat toilets remain the norm. The correlation is difficult to ignore. By civilizing the bathroom, we broke the bowel. The mechanics of the full squat also engage the abdominal cavity in a way that sitting cannot replicate. In a deep squat, the thighs act as a natural compressor for the abdomen. This external pressure supports the colon, gently squeezing the ascending and descending tracts to encourage peristalsis, the rhythmic muscle contractions that move stool through the intestines. It is a form of self-massage, a mechanical assist that increases intra-abdominal pressure without the dangerous spiking of blood pressure associated with straining. When a person sits and strains, they often inadvertently trigger the vagus nerve, which can lead to a sudden drop in heart rate and blood pressure, a phenomenon known as defecation syncope. Tragic but true, many cardiovascular events occur on the toilet because the strain of pushing against a choked rectum places immense load on the heart. The squat, by contrast, creates a pressurized environment that supports the evacuation naturally, safeguarding the cardiovascular system from the trauma of the push. Furthermore, the squat position acts as a preventative measure against pelvic floor dysfunction. In the seated position, the pelvic floor must descend significantly to allow the stool to pass, a repetitive stretching that can, over decades, lead to nerve damage and a condition known as perineal descent. This creates a vicious cycle. The more the pelvic floor sags, the harder it is to evacuate, leading to more straining and further damage. Squatting stabilizes the pelvic floor. The ischial tuberosities, the sit bones, are not bearing weight, rather the feet are. The pelvic outlet is fully opened, but the surrounding musculature is supported by the extreme flexion of the hips. This protects the delicate nerves of the pudendal canal, preserving long-term continence and sexual function. It is a protective stance, shielding the body from the wear and tear of daily elimination. However, readopting the full squat in a Western context presents significant logistical and physical hurdles. The modern Western adult has largely lost the flexibility required to perform a flat-footed deep squat. Decades of sitting in chairs, driving in cars, and wearing heeled shoes have shortened our Achilles tendons and tightened our hip flexors. For many, attempting a full squat on the floor is physically impossible without falling backward or lifting the heels, which destabilizes the posture. Moreover, our infrastructure is hostile to the squat. Standard Western toilets are raised ceramic pedestals designed for sitting.
Attempting to perch on the rim of a toilet bowl in a squatting position is incredibly dangerous. The ceramic is not rated for point load weight and can shatter, causing catastrophic injury. Thus, the full squat entry represents an ideal, the platinum standard of defecation mechanics that is often inaccessible to the average person without significant modification to their environment or their own flexibility. Despite these challenges, the resurgence of interest in the full squat speaks to a growing awareness of ancestral health. Just as we look to the diets of our hunter-gatherer forebears to solve the obesity crisis, we are looking to their postures to solve the constipation epidemic. Biohackers and pelvic floor therapists are increasingly prescribing the third world squat as a daily exercise, not just for bowel health, but to restore mobility to the hips and ankles. The act of squatting to poop is the ultimate functional movement, a daily validation of orthopedic health that we have outsourced to furniture. To return to the squat is to reclaim a fundamental aspect of being human, acknowledging that while our minds may live in the digital age, our bowels are still operating on Stone Age software. The friction between these two realities is the source of our discomfort, and the resolution lies in bending the knees, dropping the hips, and surrendering to gravity. The medical community has begun to validate what billions of people in the Eastern world have known for centuries: the squat is superior. Radiology studies utilizing defecography, a technique where X-rays capture the mechanics of defecation in real time, have provided visual proof. These images show clearly that in a squatting posture, the rectum opens more fully and evacuation is more complete. Complete evacuation is a critical concept here. Constipation is often not just frequency, but about incomplete emptying. Leaving residue in the rectum leads to hardening of the stool, increased bacterial fermentation, and the sensation of bloating. The squat ensures the tank is fully drained, reducing the risk of fecal impaction and the reabsorption of toxins. It is a cleansing posture, a total reset of the system that the seated position simply cannot achieve. Ultimately, the full squat is a reminder that comfort and health are not always synonymous. The seated toilet is comfortable. It allows us to read, to scroll on our phones, to relax in a way that the intense,
active posture of a squat does not. But this comfort comes at a price. It encourages loitering, which leads to blood pooling in the hemorrhoidal veins. It encourages passivity, which leads to atrophy of the core muscles involved in elimination. The squat is active, primal, and efficient. It demands engagement. It is a position of function, not leisure. In the war against constipation, the full squat is the nuclear option, the most powerful tool in the arsenal of biomechanics, capable of overriding the sluggishness of the modern gut through sheer geometric superiority. 2. Use a footstool on the toilet, squatty potty style, the biohacker's compromise. If the full squat is the evolutionary ideal, the toilet footstool is the necessary bridge between our primal biology and our modern infrastructure. It represents the most significant innovation in bathroom ergonomics since the invention of the flush toilet itself, yet its brilliance lies in its simplicity. We cannot reasonably expect a society built on seated plumbing to suddenly tear out its toilets and install floor-level latrines, nor can we expect a population with limited mobility to balance precariously in a deep squat. The footstool offers a sophisticated compromise. It mimics the geometry of the squat while maintaining the stability and convenience of the throne. By elevating the feet and raising the knees above the hips, the footstool biohacks the body into a simulated squat, unlocking the majority of the physiological benefits of the deep squat without the orthopedic demands. This entry explores how a simple elevation of the feet has sparked a revolution in digestive health, transforming a taboo subject into a viral conversation about the geometry of relief.
The mechanics of the footstool act as a cheat code for the puborectalis muscle. As established, the seated position keeps this muscle taut, choking the rectum. By placing a stool, typically 7 to 9 inches in height, at the base of the toilet and resting the feet upon it, the user forces their hips into flexion. This closes the angle between the torso and the thighs. While a standard sitting position creates a hip angle of 90 degrees, the use of a footstool compresses this angle to approximately 35 degrees. This specific degree of flexion is the sweet spot. It is sufficient to slacken the puborectalis sling and straighten the angle-rectal canal, yet it allows the user to remain seated on the toilet bowl. The rectum opens, the kink disappears, and the pathway is cleared. It is a triumph of geometry over anatomy, allowing the user to retain the creature comforts of the Western bathroom while accessing the efficiency of the Eastern squat. The rise of the toilet footstool, epitomized by the brand Squatty Potty but encompassing a genre of ergonomic aids, is a case study in modern cultural anthropology. For decades, the topic of defecation mechanics was shrouded in embarrassment. It was unseemly to discuss how one pooped. However, the introduction of these devices broke the silence.
Through viral marketing campaigns featuring unicorns pooping rainbow soft-serve ice cream and educational diagrams explaining the kink in the hose, the footstool movement brought medical science into the mainstream consciousness. It forced millions of people to confront the reality that they had been doing it wrong their entire lives. The footstool became a symbol of proactive health, a tool for the optimizer who seeks to improve every aspect of their biology. It shifted the narrative from constipation is a medical condition aimed at the elderly to efficient elimination is a performance metric for everyone. The ergonomic design is arbitrary. It is the result of careful calibration. A random box or a stack of books can serve a similar purpose, but purpose-built toilet stools are designed to wrap around the base of the commode, allowing them to be tucked away when not in use. This integration is crucial for adoption. If the device is cumbersome or ugly, it will not be used. The height is also specific. A 7-inch lift is standard for most toilets, but a 9-inch lift is available for higher comfort height toilets or for advanced users who possess greater hip flexibility and desire a deeper simulation of the squat. The surface usually includes a slight heel lift or texture to encourage a stable foot plaque, mimicking the grounded sensation of the earth. This attention to detail transforms the footstool from a piece of plastic into a medical device, a precision instrument for bowel realignment. The psychological impact of using a footstool should not be underestimated. There is a phenomenon known as grounding or stability that occurs when the feet are firmly planted and elevated. In a standard sitting position, especially for shorter individuals, the feet may dangle or barely touch the floor, creating a sense of instability that causes the pelvic floor to tense up reflexively. The body does not like to be suspended when it is vulnerable. By bringing the floor up to the feet, the footstool provides a solid platform. This sensory feedback tells the brain that the body is stable, allowing the parasympathetic nervous system, the rest and digest mode, to take over. The tension leaves the legs and the pelvic floor, creating a psychological state of readiness that facilitates the physical act. It turns the bathroom into a cockpit where the pilot is fully in control of the controls.
Clinical evidence supporting the use of footstools has grown alongside their popularity. Studies involving healthy volunteers have shown that using a footstool significantly reduces the duration of defecation and the subjective effort required. In one study, participants timed their bowel movements and rated their straining levels. The results were conclusive. The simulated squat provided by the footstool reduced the time spent on the toilet and drastically lowered the straining score. This has massive implications for the prevention of hemorrhoids and anal fissures. These conditions are primarily caused by the excessive pressure of straining. By simply lifting the knees, the need to strain is removed, allowing existing fissures to heal and preventing new hemorrhoids from forming. For chronic constipation sufferers, the footstool is often the first line of defense recommended by gastroenterologists, a non-invasive intervention that addresses the mechanical root of the problem before resorting to laxatives or medication. The footstool also addresses the issue of incomplete evacuation mentioned in the previous entry. Because the rectum is straightened, gravity can clear the bowel more effectively. This reduces the nagging sensation that often follows a bowel movement in the seated position, the feeling that there is still something left. This sensation often drives people to sit on the toilet for prolonged periods, straining and waiting, which is damaging to the pelvic nerves. The footstool promotes a one-and-done efficiency. The user sits, assumes the position, evacuates fully, and leaves. This reduction in loitering time is beneficial for the long-term health of the rectal veins, which can become swollen and varicose if subjected to the gravity of an open toilet bowl for too long. Furthermore, the footstool serves as a diagnostic tool. If a patient uses a footstool and finds immediate relief, it confirms that their constipation was likely dyssynergetic or mechanical in nature, a coordination issue involving the pelvic floor muscles. If the footstool provides no relief, it points to deeper issues such as slow transit constipation or dietary deficiencies. In this way, the humble plastic stool becomes a part of the diagnostic process, helping individuals understand their own bodies. It empowers the patient to take control of their digestive health through posture rather than pharmacology.
The cultural normalization of the toilet footstool marks a significant shift in Western hygiene practices. We are seeing these devices appear not just in the homes of health enthusiasts, but in luxury hotels, corporate offices, and hospitals. It signals a move away from Victorian prudishness toward a more biological realism. We are acknowledging that we are animals with specific physiological needs, and that ignoring those needs for the sake of arbitrary social norms, like sitting on a chair to poop, is foolish. The footstool is a monument to pragmatism. It admits that the toilet design was flawed and offers a patch for the system. Looking to the future, the influence of the footstool is likely to reshape the design of the toilet itself. We are already seeing high-end, smart toilets that incorporate integrated footrests that deploy at the touch of a button. Architects and designers are rethinking the bathroom space to accommodate this need for elevation. The era of the 90-degree sit is ending. The future of defecation is angular, scientific, and assisted. The footstool has proven that we do not need to abandon the porcelain throne to reclaim our health. We simply needed to upgrade it. By bridging the gap between the caveman squat and the modern man's comfort, the footstool has saved millions of colons from the tyranny of the right angle. It is the biohacker's compromise, a plastic pedestal that elevates the knees and, in doing so, elevates the entire experience of human elimination.
3. Lean forward with elbows on knees, the rodent archetype and the geometry of compression. If the full squat is the evolutionary gold standard and the footstool is the technological bridge, the lean forward position represents the intuitive, immediate adaptation of the desperate human body. It is the posture of instinct. When the bowel seize and the colon refuses to cooperate, the human frame naturally curls inward. We do not stand tall in the face of abdominal distress. We fold. This position, seated on the toilet, torso angled sharply forward, elbows resting firmly on the knees, is colloquially known as the thinker, mirroring Auguste Rodin's famous sculpture. While Rodin likely intended to depict the weight of intellectual contemplation, he inadvertently captured the universal geometry of physiological struggle. This entry investigates the profound biomechanics of this forward fold, a position that utilizes the body's own mass to generate the intra-abdominal pressure necessary to overcome the inertia of a stagnant bowel. The mechanics of the forward lean are rooted in the principles of hydraulics and leverage. When a person sits upright on a standard toilet, the abdominal cavity is elongated, the organs are stacked vertically, and the abdominal wall is relatively slack. In this vertical orientation, the generation of expulsion force relies almost entirely on the contraction of the diaphragm and the abdominal muscles, the voluntary push. However, this push is often inefficient because the force is dissipated across a loose vertical structure. By leaning forward until the chest approaches the thighs, the user fundamentally alters the shape of the container. The abdominal cavity is compressed, the space available for the viscera is reduced, which according to the principles of fluid dynamics increases the pressure within that space without any additional muscular effort. This is passive compression. The thighs, acting as a rigid backstop, press against the lower belly, while the descending rib cage presses from above. The colon is caught in this gentle vice, subjected to a steady external squeeze that encourages movement. The placement of the elbows is not merely a comfort preference, it is a structural necessity for this position's efficacy. By locking the elbows onto the knees or the distal thighs, the user creates a close kinetic chain. The arms act as struts, transferring the weight of the upper body directly into the legs.
This stabilizes the torso, allowing the abdominal muscles to relax. This relaxation is counterintuitive but critical. If the abdominal muscles are tense from trying to hold the body up, they act as a rigid wall that resists the expansion of the gut. By using the skeletal structure of the arms to support the weight of the thorax, the abdominal wall can go soft, accepting the compression of the lean. This allows the pressure to be directed inward toward the colon and rectum, rather than being wasted on maintaining posture. The elbows on knees stance effectively turns the upper body into a passive hydraulic press, utilizing gravity and body weight to do the work that the muscles are struggling to accomplish. The forward lean also mimics the hip flexion of the squat, albeit to a lesser degree. In a standard seated position, the hip angle is 90 degrees. Leaning forward to a 45 or 30-degree angle closes the hip joint, bringing the femurs closer to the torso. While this does not elevate the knees, unless combined with a footstool, the relative angle between the spine and the thigh is reduced. This relative flexion helps to partially slacken the puborectalis muscle, the anatomical chokehold discussed in previous entries. It is not as effective as the full squat or the footstool method in unkinking the anorectal angle, but it is significantly superior to sitting upright. It is the poor man's squat, a way to approximate the geometry of release using nothing but the flexibility of the spine and the rotation of the pelvis. For situations where no footstool is available, in public restrooms, airports, or office buildings, the forward lean becomes the most accessible tool in the defecation arsenal. There is a fascinating accidental convergence between this posture and modern technology. The rise of the smartphone has inadvertently standardized the lean forward position for millions of people. When scrolling through social media or reading news on a handheld device while on the toilet, the natural tendency is to lean forward, resting elbows on knees to bring the screen closer to the face and stabilize the hands. In a strange twist of fate, the device that is often blamed for distracting us and prolonging bathroom visits, leading to hemorrhoids, causes us to assume the correct biomechanical posture for elimination. However, this is a double-edged sword. While the posture is correct, the attention is fractured.
The forward lean works best when combined with mindfulness and bodily awareness. When the mind is lost in a digital feed, the autonomic nervous system may not receive the all-clear signal to release, despite the favorable geometry. The thinker pose requires thinking about the act itself, or rather feeling it, to be fully effective.
Historically, the upright sitting posture was promoted as a sign of civility and correctness in the Victorian era. Slouching or leaning was seen as lazy or uncouth. This social conditioning seeped into the bathroom, where sitting up straight was subconsciously associated with dignity. We are now unlearning centuries of poor postural programming. Medical anthropology suggests that before the advent of the chair-height toilet, the lean was not a conscious choice, but a natural consequence of using chamber pots or lower latrines. The body seeks the path of least resistance. It is only the rigid architecture of the modern porcelain pedestal that invited the error of the vertical spine. The return to the forward lean is a return to intuitive biology, a rejection of the artificial stiffness that civilization imposed on our most basic function. The lean forward position also facilitates a specific maneuver known as the pump or the rocker. Because the elbows are anchored on the knees, the user can easily rock the torso back and forth. This rhythmic movement changes the intra-abdominal pressure dynamically. Leaning forward compresses the colon, rocking back slightly releases it. This oscillation can act as a form of external peristalsis, mechanically jostling the contents of the bowel and encouraging movement. It is similar to getting ketchup out of a bottle. Sometimes a steady squeeze works, but sometimes you need to manipulate the container. The fixed point of the elbows allows for this controlled mobilization of the torso, turning the upper body into a rhythmic pump that can dislodge stubborn stool. Furthermore, this position protects the lower back. Straining on the toilet while sitting upright places immense shear force on the lumbar discs. The act of bearing down creates an explosion of internal pressure that has to go somewhere. If the core is not braced properly, it blows out against the spine. By leaning forward and supporting the weight of the upper body with the arms, the lumbar spine is placed in traction rather than compression. The vertebrae are opened up, and the spinal erectors are disengaged.
This makes the lean forward position the safest option for individuals with chronic back pain, sciatica, or herniated discs. It unloads the skeletal structure while loading the visceral structure. From a gastroenterological perspective, the forward lean is often the first piece of advice given to patients suffering from functional constipation. It is a zero-cost intervention. Unlike pharmaceutical laxatives, which carry the risk of dependency, or surgery, which carries the risk of complications, tilting the torso carries no risk. It is a mechanical adjustment that yields immediate mechanical results. Diagnostic imaging, specifically dynamic MRI of the pelvic floor, has shown that patients who lean forward exhibit a more open anorectal angle and a wider anal canal diameter than those who sit upright. The science is settled. The vertical back is an obstructionist posture. The angled back is a liberationist posture. However, the execution of the lean requires nuance. It is not simply about collapsing the chest onto the lap. The spine should remain relatively neutral, avoiding excessive kyphosis, rounding of the upper back, which can compress the lungs and hinder the diaphragmatic breathing necessary for relaxation. The hinge should come from the hips. The thinker is not slumped into feet. He is engaged in an active forward-projecting intensity. The elbows dig into the vastus medialis, inner thigh, or the patella, kneecap, creating a tripod of stability. This stability signals safety to the brain. When the body feels physically supported, locked in, grounded, stable, the pelvic floor muscles are more likely to drop their guard. In the grand scope of bathroom ergonomics, the lean forward with elbows on knees entry is the triumph of adaptation. It demonstrates the body's ability to negotiate with a hostile environment. We built toilets that don't fit our biology, so we bend our biology to fit the toilets. It is a compromise, certainly. It lacks the sheer geometric perfection of the deep squat, but it is a highly effective one. It transforms the user from a passive sitter into an active participant, utilizing the weight of the thorax and the leverage of the arms to engineer a solution to internal stagnation. It is the posture of focus, of determination, and ultimately of physics applied to the most humble of human problems.
4. Relaxed belly breathing posture, the pneumatic key to the pelvic lock. While the previous entries have focused on the external architecture of the body, the angle of the hips, the placement of the feet, the tilt of the spine, entry number 4 descends into the invisible internal world of pressure dynamics and neurology. The relaxed belly breathing posture is not a shape you make with your bones, it is a shape you make with your air. It is the master key that unlocks the door the other positions are merely knocking on. You can squat, use a footstool, and lean forward perfectly, but if your breathing is shallow and your abdomen is tight, the door will remain bolted. This entry explores the profound connection between the diaphragm and the pelvic floor, a synergistic relationship known as the piston mechanism, and how modern vanity, anxiety, and stress have destroyed our natural ability to eliminate. To understand why belly breathing is the ultimate constipation hack, we must map the anatomy of the core canister. Imagine the abdominal cavity as a pressurized cylinder. The top of this cylinder is the diaphragm, the primary muscle of respiration. The bottom of the cylinder is the pelvic floor, the hammock of muscles that supports the organs and controls the anal sphincter. These two structures are mechanically linked. They are dance partners that must move in perfect synchronization. In a healthy functional body, when you inhale, the diaphragm descends, pushing down into the abdominal cavity to draw air into the lungs. This downward pressure increases intra-abdominal volume. To accommodate this pressure, the pelvic floor must relax and descend, bulge outward,
Conversely, when you exhale, the diaphragm rises and the pelvic floor gently lifts. This is the piston, down, down, up, up. However, for millions of people, this piston is broken or frozen. This dysfunction is often rooted in the sucking in culture. From a young age, particularly in Western society, we are conditioned to hold our stomachs in. We associate a flat stomach with beauty and fitness. We maintain a chronic Mo-level tension in the rectus abdominis and obliques to hide our bellies. This constant sucking in creates a catastrophic problem for bowel movements. When the abdominal wall is held tight, the diaphragm cannot descend fully during inhalation. It hits a wall of tension. If the diaphragm cannot go down, the pressure cannot be transferred to the pelvic floor.
The piston is stuck at the top of the cylinder. The pelvic floor never receives the signal to relax and descend. Instead, it remains tight and high, keeping the anal sphincter shut. The relaxed belly breathing posture is the deliberate reversal of this conditioning. It requires the user to sit on the toilet and consciously let go of the abdominal wall. It demands the formation of a Buddha belly. The technique involves inhaling deeply through the nose, directing the air not into the chest but deep into the lower pelvis. The user must visualize the breath filling the stomach like a balloon, expanding it outward and downward. As the belly expands, the diaphragm drops like a heavy weight. This downward force gently stretches the pelvic floor muscles from the inside, signaling them to lengthen and open. It is a pneumatic wedge. Unlike straining, which is a violent muscular bearing down, often with the breath held, belly breathing is a gentle hydraulic expansion. Straining tightens the sphincter, belly breathing opens it. This technique is deeply intertwined with the autonomic nervous system, ANS. The act of defecation is governed by the parasympathetic nervous system, the rest and digest branch. Its opposite, the sympathetic nervous system, is the fight or flight branch. When we are stressed, rushing, or anxious about not being able to poop, the sympathetic system takes over. Blood is shunted away from the digestive tract to the limbs, heart rate increases, and crucially, the anal sphincters tighten. This is an evolutionary defense mechanism. You do not want to defecate while running from a predator. Unfortunately, many people approach the toilet with a fight mindset. They are frustrated, late for work, or in pain. They attack the bowel movement. This sympathetic activation locks the door. Deep, slow belly breathing is the most effective way to manually override the stress response. By slowing the respiration rate and engaging the diaphragm, we stimulate the vagus nerve. The vagus nerve is the superhighway connecting the brain to the gut. Stimulation of this nerve sends a powerful all-clear signal to the body, shifting the system from sympathetic, fight, to release. As the exhalation extends, the heart rate slows, the jaw relaxes, which is neurologically connected to the pelvic floor, and the tension in the anal sphincters melts away. The relaxed belly breathing posture is therefore
As much a psychological intervention as a physical one, it turns the bathroom into a meditation chamber, using breath to quell the performance anxiety that exacerbates constipation. The specific mechanics of the relaxed belly breathing involve what pelvic floor therapists call the reverse Kegel. Most people are familiar with Kegels, the contraction of pelvic muscles to stop urine flow. A reverse Kegel is the opposite, the conscious bulging and relaxation of the perineum. Belly breathing is the engine that drives the reverse Kegel. As the user inhales and pushes the belly out, they should feel a distinct sensation of dropping in the area between the sit bones. It is a feeling of opening a flower. This is the internal anal sphincter, a muscle we cannot voluntarily control like a bicep, responding to the pressure cues of the breath. We cannot will the internal sphincter to open. We can only create the environment, pressure and relaxation, in which it chooses to open. Belly breathing creates that environment. This posture also addresses the issue of paradoxical contraction, a condition known as dyssynergic defecation. In healthy subjects, when they push to poop, the anus relaxes. In patients with dyssynergia, when they push, the anus inadvertently contracts. They are stepping on the gas and the brake at the same time. This is a motor control error, often caused by years of straining. Belly breathing retrains this coordination. By removing the push, the gas, and focusing entirely on the release, taking the foot off the brake, the body relearns the natural rhythm of elimination. The instruction is often, don't push the stool out, breathe the stool out. The cultural implications of this entry are vast. It challenges the modern obsession with the hard body. It suggests that our vanity is making us sick. To poop well, one must be soft. One must be willing to look distended, unposed, and vulnerable. The relaxed belly breathing posture is a rejection of the corset, both the literal corsets of the past and the muscle corsets of the present. It aligns with ancient practices like yoga and qigong, which have long understood that energy and waste can only flow through a relaxed vessel. In yoga, apana vayu is the energy of downward elimination. The practices to cultivate apana involve grounding and deep abdominal respiration, identical to the medical advice now given by top gastroenterologists. Furthermore,
this breathing posture acts as a safeguard against the cardiovascular dangers of the toilet. As mentioned in previous entries, the Valsalva maneuver, holding breath and straining, spikes blood pressure and intracranial pressure. This can lead to fainting, strokes, or burst blood vessels in the eyes. Belly breathing ensures continuous oxygenation. There is no breath holding. There is no spike in pressure. The pressure generated is low grade, constant, and safe. It is the difference between trying to smash a door down, straining, and gently leaning against it until the latch gives way, belly breathing. For elderly populations or those with heart conditions, adopting the relaxed belly breathing posture is a life-saving modification.
In practice, this position transforms the user's presence on the toilet. The eyes may close, the hands may rest gently on the abdomen to monitor the expansion. The focus turns entirely inward. It is a moment of interoception, listening to the internal signals of the body. The user visualizes the breath traveling down the spine, past the diaphragm, into the pelvis, and out. This visualization, combined with the pneumatic pressure of the diaphragm, is often the final piece of the puzzle for chronic constipation sufferers. They have the squatty potty, entry number 2. They are leaning forward, entry number 3. But until they unlock the breath, entry number 4, they are merely compressing a closed system. The relaxed belly breathing posture asserts that the most powerful muscle for defecation is not the rectum nor the abs, but the diaphragm. It is the silent pump that drives the entire hydraulic system of the human trunk. By mastering this breath, by daring to let the belly go soft and big, we reclaim control over the autonomic functions that civilization has disrupted. It is the ultimate act of letting go, proving that in the end, relief comes not from force, but from flow.
5. The Mu breathing technique position, sonic resonance and the glottis-pelvic connection. In the hushed, sterile libraries of modern etiquette, the bathroom is designated as a zone of absolute silence. We are taught from childhood that the functions of the body should be invisible and, crucially, inaudible. This social contract, however, stands in direct opposition to the physiological realities of the human machine. The Mu breathing technique, a position that is as much an acoustic event as it is a physical posture, challenges the tyranny of silence. It posits that sound is not merely a byproduct of effort, but a functional tool for opening the body. This entry investigates the fascinating, often overlooked neurological highway connecting the throat to the pelvic floor, revealing why a low-frequency vocalization is the secret code to overriding the sphincteric locks of the constipated body. To understand why mooing works, we must first map the sphincter law of the human body, a principle often cited in pelvic floor physical therapy and vocal coaching. The anatomy of the human trunk is bracketed by 2 primary diaphragms, the vocal diaphragm, the glottis and vocal folds at the top, and the pelvic diaphragm, the pelvic floor, at the bottom. These 2 structures are embryologically and neurologically linked via the vagus nerve and the continuous fascial tube of the digestive tract. There is a sympathetic resonance between them. When the jaw is clenched and the throat is tight, a common reaction to stress or the effort of straining, the pelvic floor reflexively tightens. The body perceives tension at the top and mirrors it at the bottom. This is the closed cylinder effect. Conversely, when the throat is open and the jaw is relaxed, the pelvic floor receives a neurological signal to soften. The Mu technique exploits this connection. The mechanics of the Mu are specific and require precision. This is not a random shout, but a controlled resonant exhalation. The user assumes the lean forward posture, entry number 3, or utilizes the footstool, entry number 2, but the critical action occurs in the respiratory system. Instead of holding the breath to bear down, the dangerous Valsalva maneuver, the user inhales deeply into the belly and then exhales slowly while producing a low-pitched humming sound. This sound is not chosen for its bovine association, but for its acoustic properties. The M sound vibrates the lips and the front of the face.
Ensuring the jaw is loose, the U vowel is an open throat vowel. It depresses the larynx and opens the glottis. As the user sustains this low note, the vibration travels down the spine and into the pelvic bowl. This is not metaphorical. Low-frequency sound waves physically penetrate tissue more effectively than high frequencies. The vibration acts as a gentle internal massage, shaking loose the microtension in the pelvic floor muscles. The Mu technique fundamentally changes the pressure dynamics of defecation. When a person strains in silence, Valsalva, they close their glottis, hold their breath, and push. This creates a high-pressure system in the chest and head, which can lead to burst blood vessels in the eyes, headaches, and even fainting. However, the pressure in the abdomen is often undirected or erratic. When utilizing the Mu, the glottis remains open to allow air to escape, but the vocal folds provide a regulated resistance. This is known as back pressure. This resistance keeps the diaphragm depressed for longer, maintaining steady, safe intra-abdominal pressure that pushes down on the rectum without spiking blood pressure in the head. It effectively turns the torso into a controlled pneumatic piston rather than a pressurized bomb. The sound is the audible proof that the glottis is open and the pressure is being managed safely. This technique finds its historical and cross-cultural roots in the birthing rooms of the world. Midwives have known for centuries that a silent labor is often a stalled labor. In the throes of childbirth, which utilizes the same expulsive machinery as defecation, albeit at a much higher intensity, women are encouraged to make low, guttural sounds. High-pitched screaming tightens the throat and the cervix pelvic floor, causing pain and delaying progress. Low-pitched moaning or chanting opens the body. The Mu technique is simply the application of this obstetrical wisdom to the daily active bowel movements. It is low sounds, low exit. By adopting the vocalizations of labor, the constipated individual taps into a primal biological program for expulsion that bypasses the anxious, aching brain.
The psychological component of the moo cannot be overstated. Constipation is often a state of freezing, a sympathetic nervous system response where the body refuses to let go. The act of making a sound is an act of release. It breaks the tension of the moment. It requires a certain vulnerability.
To sit on a toilet and moo is to abandon the pretense of being a polished, civilized entity and to accept one's animal nature. This psychological surrender often triggers the physical surrender of the anal sphincter. Furthermore, the vibration of the vagus nerve, which passes through the vocal cords during humming or chanting, stimulates the parasympathetic nervous system, rest and digest. The moo is essentially a self-soothing mechanism, a lullaby for the anxious gut that downregulates the stress response and permits peristalsis to resume. However, the greatest barrier to the moo breathing technique is social embarrassment. In the modern world, our bathroom stalls are rarely soundproof. The fear of being heard by a spouse, a coworker, or a stranger in the next stall is a potent inhibitor. This paresis or shy bowel syndrome causes many people to hold their breath and strain silently to avoid drawing attention. This silence is pathogenic. It forces the body to work against itself. The adoption of the moo requires a radical shift in mindset, a prioritization of health over social camouflage. It asks the user to declare sonically that they are engaging in a biological function. In Japan, the invention of the otohime or sound princess, a device that plays the sound of flushing water to mask bodily noises, speaks to the intense shame surrounding bathroom acoustics. The moo technique argues that we should not mask the sound but change the sound from one of struggle to one of therapeutic resonance. The physics of the moo also engage the core musculature in a unique way. To sustain a long, steady note, the transverse abdominis muscle must contract gently to push the air out. This is a forced exhalation. This gentle contraction of the deep abs provides exactly the right amount of external squeeze on the colon to assist with evacuation, without the violent shearing force of a grunt. It coordinates the breath with the push. It creates a rhythm. Inhale, belly expands. Exhale, moo, belly draws in slightly, diaphragm creates pressure, pelvic floor opens. This rhythmic cycle prevents the fatigue that comes from continuous straining. It breaks the act down into manageable reps, preventing the user from becoming exhausted and overwhelmed. Medical professionals, particularly those in the field of pelvic floor dysfunction, are increasingly prescribing vocalization as a therapeutic intervention.
Biofeedback machines can visualize the connection. When a patient hums a low note, the sensors on the pelvic floor show a drop in resting tension. When they hiss or scream a high note, the tension spikes. The data is irrefutable. The voice is a remote control for the pelvis. For patients with paradoxical contraction, where the anus tightens when trying to poop, the moo is often the breakthrough tool. It gives the brain a new task to focus on, making the sound, which distracts it from the habitual pattern of clenching the butt. Looking to the future, as we become more comfortable with biohacking and somatic therapy, the moo may shed its stigma. We may see the introduction of sound dampening technology in residential and public bathrooms, not just for privacy, but to encourage therapeutic vocalization. We might envision a future where the sound of low humming in a restroom is not met with confusion, but with a knowing nod to biomechanical efficiency. The moo breathing technique is a reminder that the body is a single integrated instrument. You cannot tighten the strings at the headstock and expect the bridge to be loose. To open the gates below, we must first open the gates above, using the resonant power of our own voice to sing the body into a state of release.
6. Knees wide, feet stable, the architecture of the pelvic outlet. If the moo technique explores the vertical axis connecting the throat to the bowel, the knees wide, feet stable position explores the horizontal axis of the pelvic girdle itself. This entry delves into the structural engineering of the hips and the crucial concept of abduction in the elimination process. For decades, the standard image of a person sitting on a toilet involves the knees kept relatively close together, parallel to the hips, a posture dictated by the narrow design of toilet bowls and the modesty of clothing, pants around the ankles. However, this parallel leg alignment is an anatomical error. It mechanically narrows the pelvic outlet, effectively squeezing the exit shut. Entry number 6 argues that to evacuate efficiently, one must adopt a wide stance, a power pose of defecation that physically pries apart the ischial tuberosities and creates the necessary space for the rectum to do its work. The anatomy of the pelvis is not a solid fused ring of bone. It is a dynamic structure held together by ligaments and joints, specifically the sacroiliac SI joints and the pubic symphysis. While the movement at these joints is subtle, measured in millimeters, it is critical. When the femurs, thigh bones, are rotated internally or kept parallel, the soft tissue and musculature of the buttocks are compressed toward the midline. More importantly, the obturator internus muscle, a deep hip rotator that lines the inside of the pelvic wall, remains short or neutral. This muscle has a direct fascial connection to the levator ani, the muscle group that makes up the pelvic floor. When the knees are close together, the tension in the hip rotators can keep the pelvic floor in a state of partial suspension, narrowing the anal canal. By widening the knees, abducting the hips well past the width of the shoulders, the user initiates a chain reaction of opening. The external rotation of the femur stretches the adductor muscles inner thigh and alters the tension in the obturator internus. This action mechanically encourages the ischial tuberosities, the sit bones, to flare outward. It creates a sensation of blooming at the base of the pelvis. The soft tissue of the gluteals is pulled away from the anal opening, removing the physical sensation of blockage. This is the knees-wide component. It is the architectural equivalent of opening the blast doors. The wider the stance,
The broader the base of the pelvic floor, and the less resistance the stool encounters as it exits the body. However, the width of the knees is useless without the second component, feet stable. This is the anchor. In a bathroom setting, floors can be slippery, and the user is often wearing socks or has their pants binding their ankles, which forces the feet together. If the feet are close together while the knees try to spread, the user is in an unstable, leveraged position that strains the ankles and knees. The body, sensing this instability, will reflexively tighten the core and pelvic floor to prevent falling. This is the fear of falling reflex. To truly relax the pelvic floor, the feet must be planted firmly, wider than hip width apart. This requires the user to physically move their feet out, potentially wrestling with their clothing to create slack. The stability of the feet provides what kinesiologists call ground reaction force. When the feet are planted wide and solid, the user can push slightly outward against the floor. This engagement of the outer hip muscles, the gluteus medius, reciprocally inhibits the adductors and the pelvic floor. It tells the nervous system, I am grounded, I am stable, it is safe to open. This creates a tripod effect, foot-foot toilet seat, that is incredibly secure. In this stable, wide-base position, the abdominal muscles can generate pressure without the pelvic floor contracting in a panic response. The feet stable instruction is the foundational assurance that allows the knees-wide geometry to function. This position also serves to recontextualize the controversial cultural phenomenon of manspreading. While socially criticized when performed on crowded subways, structurally the wide knee stance is the biological default for the male pelvis and largely the female pelvis when at rest or under load. The modern toilet with its narrow oblong rim subtly encourages a narrow stance. We are conditioned to keep our knees together as a sign of propriety, but propriety is the enemy of peristalsis. The knees-wide entry validates the biological necessity of taking up space. It argues that the bathroom is not a place for modesty, it is a place for mechanics. To poop effectively is to claim territory, to spread the limbs, and to maximize the aperture of the body.
The knees-wide position is particularly effective for individuals who suffer from outlet obstruction constipation, a condition where the stool reaches the rectum but cannot pass the final gate. Often, these individuals feel a sensation of hitting a wall. This wall is frequently their own soft tissue and muscle tension compressing the canal. By widening the knees, the user manually pulls apart the tissues. It is a form of self-manipulation. Imagine trying to squeeze toothpaste out of a tube while pinching the nozzle. Widening the knees is the equivalent of releasing the pinch. It changes the shape of the container from a narrow V to a wide U. Furthermore, this position helps to align the colon. The colon runs up the right side of the abdomen, across the top, and down the left side. When the legs are squeezed together, the lower abdomen is compressed laterally. When the knees open wide, the lower belly is allowed to hang forward and spread, synergizing with entry number 4, belly breathing. This gives the sigmoid colon, the final S-shaped curve before the rectum, more room to maneuver. It uncramps the lower abdominal quadrant, reducing the pain associated with gas and bloating. The wide stance allows the organs to settle into their natural gravity-dependent positions without being squashed by the thighs. There is also a tactile feedback loop involved. When the knees are together, the skin of the inner thighs may touch and the buttocks are pressed together. This sensory input tells the brain closed. When the knees are wide, air circulates, the thighs are separate, and the buttocks are spread. This sensory input tells the brain open. It is a subtle but powerful psychosomatic cue. The physical feeling of openness precipitates the physiological act of opening. The implementation of knees-wide, feet stable often requires overcoming the logistical hurdles of modern clothing and bathroom design. Pants and underwear, when pulled down to the ankles, act as a shackle, binding the feet together and preventing the necessary wide stance. The knees-wide protocol demands that the user either remove one leg from their pants entirely, allowing full freedom of movement, or stretch the elastic of their garments to the limit to achieve a wide base. It suggests that the pants around the ankles trope is actually a major contributor to constipation. It restricts the range of motion of the hips.
Serious practitioners of this position often strip completely from the waist down to ensure zero restriction, allowing the femurs to abduct fully to 45 degrees or more. Future toilet design may need to reckon with the knees-wide imperative. Current toilets are designed as pedestals with narrow footprints. A biomechanically correct toilet would perhaps feature footrests or platforms built into the floor on either side, encouraging a wide stance. It would look less like a chair and more like a saddle or a cockpit. We are already seeing squatty potty devices that are adjustable or wider to accommodate this stance. The evolution of bathroom furniture is trending towards width.
Ultimately, knees wide, feet stable is a lesson in structural liberation. It teaches us that compression is the enemy of flow. By stabilizing the foundation, the feet, and opening the architecture, the knees, we create a physical environment that welcomes release. It is a stance of confidence, stability, and anatomical truth, proving that sometimes the best way to solve a problem is to simply broaden your base and stop squeezing yourself into a shape that doesn't fit the function.
7. 1 foot slightly higher asymmetrical foot support, the kinetic shift and the breaking of symmetry. In the rigid, standardized world of Western plumbing, symmetry is the law. The toilet is centered in the stall, the seat is a perfect oval, the user is expected to sit with hips square, feet planted evenly, and spine vertical. We approach the act of defecation as if we are statues placed upon a pedestal, frozen in a posture of bilateral equality. However, nature abhors straight lines and perfect symmetry. The internal landscape of the human body is a chaotic, asymmetrical masterpiece. The liver is on the right, the spleen is on the left, the heart is offset, and crucially, the colon winds through the abdomen in a tortuous, uneven path. Entry number 7 challenges the tyranny of the symmetrical sit. It posits that because the bowel itself is not symmetrical, our posture should not be either. By raising 1 foot higher than the other, utilizing an asymmetrical foot support, we unlock the power of pelvic torsion, a biomechanical hack that uses the body's own rotational force to navigate the complex topography of the sigmoid colon. To understand the genius of the asymmetrical stance, often improvised by desperate sufferers placing 1 foot on a trash can, a yoga block, or the toilet base itself, we must first dissect the anatomy of the stuck sensation. The journey of stool through the large intestine is not a straight shot. The final leg of the journey involves the sigmoid colon, an S-shaped loop of bowel that connects the descending colon to the rectum. This structure is notoriously variable. In some people it is short and direct, in others it is redundant, loopy, and prone to kinking like a garden hose. When a person sits perfectly square, the sigmoid colon can become compressed against the pelvic sidewall or folded over on itself, creating a mechanical obstruction. No amount of straining can push a solid object through a kinked tube. The tube must be straightened. This is where the Captain Morgan pose, lifting one leg high, comes into play. When you raise 1 foot significantly higher than the other, say placing the left foot on a 9-inch stool while the right foot remains on the floor, you initiate a chain reaction in the pelvic girdle. This action forces the ilium, hip bone, on the raised side to rotate posteriorly. Simultaneously, the lumbar spine side bends and rotates slightly. This corkscrew motion of the skeletal structure exerts a shearing force on the soft tissues within the pelvic bowl. It effectively wrings out the lower abdomen. By shifting the angle of the pelvis, you are physically manipulating the position of the sigmoid colon relative to the rectum. You are unkinking the hose. It is similar to the way one might jiggle a key in a lock. If it doesn't turn when held straight, you apply a slight angle, a bit of torsion, and suddenly the bolt slides free. The asymmetrical foot support is the jiggle that aligns the internal tumbler. The biomechanics of this position also heavily involve the psoas muscle, often referred to as the muscle of the soul by bodyworkers due to its deep connection to the sympathetic nervous system. The psoas major originates from the lumbar vertebrae, passes deep through the abdomen, and inserts onto the femur. It is the primary hip flexor. Crucially, the colon sits directly anterior to the psoas muscle. When you lift one knee high, flexing the hip, the psoas muscle on that side contracts and bulges. This contraction acts as an internal massage mechanism. The bulging psoas presses against the cecum on the right or the sigmoid colon on the left, providing a form of internal acupressure that can stimulate peristalsis. By alternating legs, lifting the left and the right, the user creates a walking motion within the abdomen, a rhythmic kneading that encourages the stool to move through the final turns of the maze. This concept of dynamic defecation stands in stark contrast to the static defecation encouraged by modern toilets. For most of human history, defecation was an active process. Squatting in the wild is rarely a static hold. It involves shifting weight, swatting flies, looking around, and adjusting balance on uneven terrain. These micro-movements are essential. They keep the fascia, the connective tissue webbing that holds the organs in place, pliable. When we sit on a toilet like a stone gargoyle, the fascia locks up. The asymmetrical foot support reintroduces this ancestral dynamism. It allows the user to shift their center of gravity, exploring different angles of pelvic tilt until they find the specific geometry that releases the blockage. It turns the user from a passive passenger into an active driver of their own biology. The use of asymmetrical support is particularly effective for individuals with pelvic floor hypertonicity or tight pelvic floor. In these individuals,
the muscles are chronically shortened and unable to relax. Symmetry often reinforces this tension because the body recognizes the sitting pattern and engages the holding muscles. Breaking the symmetry disrupts the pattern. When one leg is lifted, the pelvic floor muscles on that side are put on slack, while the other side is lengthened. This differential tension confuses the guarding reflex. The brain, forced to process this novel, uneven position, often relinquishes its grip on the sphincter. It is a neurological sleight of hand. By focusing on the awkwardness or the novelty of the leg position, the subconscious mind stops micromanaging the anus, allowing the autonomic functions to take over. There is also a profound gravitational component to the asymmetrical stance. When you lift one leg, you shift the weight of the abdominal viscera. If you lift the left leg, the organ slides slightly to the right, and vice versa. This visceral slide is critical for unsticking stool that may be trapped in a diverticulum or a sharp bend. We often think of the abdomen as a packed suitcase where nothing moves, but in reality, the organs are meant to glide past each other on lubricated surfaces. Dehydration and inflammation can cause these surfaces to become sticky, adhesions. The twisting and shifting of the asymmetrical pose help to break these minor adhesions, freeing the colon to expand and contract. It is a form of self-administered visceral mobilization, a technique used by osteopaths to treat constipation, but performed intuitively by the user. Historically, we can see evidence of asymmetrical defecation postures in art and anthropology. Depictions of figures in ancient Greece or Rome often show a relaxed contrapposto stance, even when seated. The rigid militaristic symmetry of the 20th century bathroom is an anomaly. It reflects the industrial design aesthetic of the machine age, straight lines, uniform curves, standardized parts, rather than the organic reality of the body. The Captain Morgan maneuver is a rebellion against this industrialization. It is a reclaiming of the body's right to move, to adjust, and find its own path. It acknowledges that today's bowel movement might require a different angle than yesterday's, depending on what was eaten, how much water was drunk, and the specific consistency of the waste. Practical application of this technique requires improvisation, as few products are designed for it.
Users often utilize a standard squatty potty but place only one foot on it, leaving the other on the floor. Others use a yoga block, a small trash bin, or even the toilet roll holder, though this is structurally unsound and dangerous. The key is the differential. The height difference between the feet should be significant, at least 6 to 10 inches. The user should feel a distinct stretch in the glute and lower back on the raised side. It is often recommended to start by raising the left leg, as this compresses the left side of the abdomen where the descending colon resides, potentially increasing pressure on the exit path. However, alternating is best. It is a process of rocking the baby out, using the legs as the rockers. The asymmetrical foot support also engages the proprioceptive system, the body's sense of where it is in space. When we sit symmetrically, our proprioception is dulled, we tune out. When we assume an asymmetrical pose, our senses wake up. We become acutely aware of the imbalance. This heightened sensory state can actually improve the nerve signaling to the bowel. The gastrocolic reflex, the signal to poop after eating, is often weak in constipated individuals. By amplifying the sensory input from the hips and pelvis through extreme positioning, we can turn up the volume on the body's internal signals, making the urge to push more distinct and coordinated. In the future of ergonomic design, we may see toilets with adjustable independent footrests, pedals that can be raised or lowered individually like the controls of a heavy excavator. This would acknowledge the medical reality that the perfect pooping position is not a static ideal, but a dynamic range of motion. Until then, the asymmetrical foot support remains a powerful tool in the arsenal of the constipated. It teaches us that when we feel blocked, the answer is not to push harder in the same direction, but to change the angle of attack. It validates the instinct to squirm, to twist, and to lift a leg, proving that in the complex physics of the human bowel, a little asymmetry goes a long way towards restoring the flow.
8. Gentle side lean, left side focus, the gravity slide, and the colonic highway. If the asymmetrical foot support is about skeletal torsion, the gentle side lean is about fluid dynamics and the strategic utilization of gravity. Specifically, it is about the left side rule of gastroenterology. The human colon is not a symmetrical horseshoe, it is a directional highway with a specific flow of traffic. It ascends on the right, crosses the middle, and descends on the left. This anatomical fact is the cornerstone of entry number 8. When a person sits upright or leans to the right, they are essentially ignoring the map of the territory. However, by performing a gentle, sustained lean to the left, the user aligns their torso with the final, downward trajectory of the digestive tract. This entry explores why listing to port is the ultimate maneuver for clearing the descending colon, creating a gravity slide that transforms a struggle against friction into a smooth descent. To appreciate the necessity of the left side focus, we must trace the path of the fecal train. After nutrient absorption is completed in the small intestine, liquid waste enters the cecum on the lower right side of the abdomen. It travels up the ascending colon, fighting gravity, crosses the transverse colon, horizontal, and then hits a crucial junction known as the splenic flexure. This is the sharp turn located directly under the left rib cage near the spleen. From here, the waste enters the descending colon, traveling down the left side of the body toward the sigmoid and the rectum. The splenic flexure is the highest point of the colon and often the sharpest angle. It is a common site for gas entrapment and blockage. Ideally, gravity should help the stool fall from this high point down to the exit. However, if the colon is sluggish or the stool is hard, it can get hung up at this turn. When a user on the toilet leans to the right, they are physically compressing the ascending colon, which is already empty or dealing with liquid, and stretching the descending colon open, but in a way that creates an uphill angle for the splenic flexure. It is counterproductive. However, when the user leans to the left, a profound geometrical shift occurs. The splenic flexure is opened and lowered. The angle between the transverse and descending colon becomes less acute, turning a sharp corner into a gentle curve. Furthermore, the weight of the abdominal organs shifts to the left, creating a gentle external compression on the descending colon. This is the squeeze tube effect. By leaning into the left side, you are essentially pressing the toothpaste tube from the top down, using your own ribcage and oblique muscles to guide the stool toward the exit. This position is deeply rooted in the principles of visceral manipulation and massage. Massage therapists are trained to massage the abdomen in a clockwise direction, looking at the patient, to follow the flow of the colon.
They push up the right, across the top, and down the left. The gentle side lean is a self-sustained version of this down the left pressure. By collapsing the left waist, bringing the left rib cage closer to the left hip bone, the user increases the intra-abdominal pressure, specifically in the left lower quadrant. This is where the backlog of constipation usually resides. The pressure is targeted exactly where it is needed, rather than being dispersed generally throughout the gut. It is a sniper approach to expulsion, rather than a shotgun approach. The left side focus also has a significant relationship with gas release. Flatus is often the precursor to stool. If the gas cannot escape, the stool acts as a cork. Gas rises. In the colon, gas often gets trapped in the high corners, the hepatic flexure on the right and the splenic flexure on the left. Leaning to the left changes the hydrostatic pressure in the bowel. It allows the gas bubbles trapped in the transverse colon to migrate towards the descending colon and eventually the rectum. Many people find that leaning to the left instigates a release of gas, which depressurizes the system and allows the stool to drop down. It functions as a pressure release valve. The fart then poop sequence is a classic sign of a successful left side lean. There is a historical and cultural parallel to be found in sleeping positions. For centuries, Ayurvedic medicine and modern gastroenterologists alike have recommended sleeping on the left side, Sims position, for better digestion and to prevent acid reflux. The logic is identical. The stomach curves to the left, and the colon descends on the left. Lying on the left allows gravity to move food from the small intestine to the large intestine and eventually to the rectum. The gentle side lean on the toilet is simply the vertical application of this horizontal rule. We are conditioned to know that the left side is the digestive side.
Yet we often forget this when we sit on the toilet. We sit upright, fighting the very asymmetry that could save us. The execution of this lean requires more than just tilting the head. It must be a C-curve of the spine. The user should anchor their sit bones firmly, then arc their entire upper body to the left, perhaps resting the left elbow on the left knee, or even reaching the left hand down toward the floor, the ground touch. This deep lateral flexion stretches the right side of the torso, opening the ascending colon, and compresses the left side. It creates a gradient. Imagine a gutter on a roof. If the gutter is perfectly flat, the water stands still. If you tilt the gutter, the water flows. The left side lean tilts the biological gutter. It provides the slope necessary for movement. This position is also a remedy for the stuck sensation in the rectum itself. The rectum is not a straight vertical tube. It follows the curve of the sacrum. Sometimes stool can become lodged in the rectal vault, just above the anal sphincter. Leaning to the left changes the angle of the rectal canal relative to gravity. It can shift the fecal mass just enough to align it with the anal opening. It is a game of angles. Users often report that leaning left and rocking slightly, combining with entry number 3, provides the final nudge needed for complete evacuation. It solves the problem of turtling, where the stool is present but refuses to exit. Culturally, the concept of the left side focus exposes a design flaw in our bathroom accessories. Toilet roll holders are placed randomly on the right or left, often dictated by the wall location rather than ergonomics. Grab bars and handicap stalls are usually bilateral. There is no architectural cue to lean left. A biomechanically advanced bathroom might feature a sturdy armrest or support specifically on the left side to encourage this posture. We have designed our environment for symmetry, but our biology demands directionality. The toilet of the future should perhaps be canted or provide a left side bolster, subtly guiding the user into the optimal gravitational alignment. The gentle side lean also forces a mental shift. It requires the user to visualize their own anatomy. To use this technique effectively, one must have a rough mental map of where the colon is. Down the left becomes a mantra. This visualization, sending the breath and the intention down the left side of the body, can act as a form of biofeedback.
The brain directs blood flow and nerve energy to the area of focus. By physically leaning into the problem area, we are mentally inhabiting it as well. We are no longer trying to escape the body or the discomfort. We are leaning into it, literally and metaphorically. Furthermore, this position is incredibly safe. Unlike extreme straining or contorting, leaning to the left carries virtually no risk of injury. It is accessible to the elderly, the pregnant, and the immobile. It is a gentle assist. It acknowledges that sometimes the body doesn't need force. It just needs a little help from physics. It is the path of least resistance. By aligning the colon with the vector of gravity, we stop fighting the uphill battle. In conclusion, the gentle side lean is the master key of gravitational defecation. It honors the asymmetrical reality of the human viscera. It recognizes that the colon is a one-way street with a very specific off-ramp located on the left side of the body. By tilting the torso, we turn the static bowl of the pelvis into a dynamic chute. We utilize the weight of our own ribs to massage the descending colon. We use the angle to release trapped gas, and we use gravity to do the heavy lifting. In a world that tells us to sit up straight, the left side focus tells us that it is okay to lean, to slouch, and to slide our way to relief.
9. Hug your knees, deep squat off toilet, the pre-evacuation ritual, and the visceral compression.
The investigation into the mechanics of defecation has thus far focused on the toilet itself, the porcelain throne that dictates our posture. However, entry number 9 posits a radical shift in perspective. The most important part of the bowel movement may actually occur before one even enters the bathroom stall, or at the very least before one sits on the commode. The hug your knees position, performed as a deep squat on the floor or a supine compression on a mat, is the pre-game strategy of the constipated elite. It is a maneuver of extreme compression, a deliberate manual override of the abdominal cavity designed to mechanically stimulate the enteric nervous system and physically force gas and waste toward the exit. This entry explores the concept of staging, the lost art of preparing the body for elimination through ground-based movement, and the profound physiological benefits of the fetal tuck. To understand the efficacy of hugging one's knees, we must look to the discipline of yoga, which has preserved ancient physiological wisdom that Western medicine is only now beginning to quantify. In yoga, there is a specific posture known as Pavana Muktasana, which literally translates to wind-relieving pose. The practitioner lies on their back, draws both knees into the chest, wraps their arms around the shins, and squeezes. This is not merely a stretch, it is a mechanical pump. By compressing the thighs against the ascending colon on the right and the descending colon on the left, the practitioner creates a massive spike in intra-abdominal pressure. This pressure is not generated by straining the diaphragm, as in the Valsalva maneuver, but by external compression. It is the difference between trying to blow air out of a balloon and simply squeezing the balloon with your hands. The hug your knees position squeezes the balloon of the bowel, forcing trapped gas, the cork of constipation, to move toward the rectum. The upright version of this, the deep squat on the floor while hugging the knees, adds the element of gravity to the compression. In this position, the user drops into a full, flat-footed squat, or on the balls of the feet if flexibility is limited, and wraps their arms tightly around their legs, curling the head down. This creates a ball shape. This configuration achieves maximum flexion of the hip joints and the lumbar spine.
From a neurological standpoint, this flexion is significant. It opens the posterior chain of the body, stretching the fascia of the lower back. The nerves that innervate the bowel exit the spine in the lumbar and sacral regions. When the lower back is tight and compressed from hours of sitting in office chairs, these nerve signals can be dampened or agitated. By rounding the back in a deep knee hug, the user performs a lumbar decompression, opening the neural pathways that signal the colon to move. It is a hardware reset for the lower trunk. The primary target of the hug your knees maneuver is the gastrocolic reflex. This is the physiological trigger that tells the colon to empty when the stomach is full. Usually, eating a meal stimulates this. However, in chronic constipation, this reflex is often dormant or sluggish. The deep compression of the thighs against the belly mimics the pressure of a full stomach. It manually stimulates the stretch receptors in the abdomen. The body senses this intense pressure and interprets it as a signal to clear space. By hugging the knees for 2 to 5 minutes before sitting on the toilet, the user can wake up a sleepy colon, generating a genuine urge to defecate. This distinction is critical. One should not sit on the toilet to wait for an urge, one should sit on the toilet to answer an urge. The knee hug generates the answer. This position also addresses the issue of splinting. Splinting is a technique often used by women with rectoceles, a prolapse where the rectum bulges into the vagina, or severe constipation, where they must physically press on the perineum or abdomen to help stool pass. Hugging the knees is a form of whole-body splinting. The thighs act as a rigid wall. As the colon contracts, it pushes against this wall. Because the wall, the thighs, does not give way, the force is directed entirely downward toward the anus. It creates a path of least resistance. For individuals with weak abdominal muscles who cannot generate enough internal pressure to poop, the legs provide the external bracing necessary to get the job done. Historically, the hug your knees posture mimics the resting position of our Paleolithic ancestors. Before the invention of chairs, humans rested in a deep squat. This was not an exercise, it was a lifestyle. In this resting squat, the abdomen was naturally compressed and the hips were constantly mobilized. Digestion occurred in this folded state.
Our modern digestive tracts are essentially lonely for this contact. They are designed to be massaged by the movement of the femurs. When we walk, the psoas muscles massage the gut. When we squat, the thighs massage the gut. The sedentary modern life removes this external massage, leaving the bowel stagnant. The knee hug restores the contact, reminding the viscera of the tactile environment they evolved in. There is also a profound psychological element to the fetal position. It is the position of safety, of regression, and of comfort. Constipation is often a somatic manifestation of holding on to stress, control, or emotion. The body tightens up. By curling into a ball, the user physically embodies the state of protection. This signals the amygdala, the fear center of the brain, to stand down. When the brain feels safe, the sympathetic nervous system, fight or flight, deactivates, and the parasympathetic nervous system, rest and digest or eliminate, takes over. We often see toddlers instinctively assume this position when they are struggling with a bowel movement. They go into a corner and curl up. They are intuitively accessing the geometry of safety and compression. We educate this instinct out of them by forcing them to sit upright on a potty, but the instinct remains correct. The deep squat off toilet also serves a logistical purpose. It separates the struggle from the act.
One of the most damaging habits in chronic constipation is associating the toilet with failure. If a person sits on the toilet for 20 minutes straining and failing, the brain begins to link the porcelain seat with frustration and pain. By moving the struggle face to the floor, hugging the knees, rocking back and forth, breathing deeply, the user breaks this negative association. The floor is for working, the toilet is for releasing. The user remains on the floor in the knee hug position until they feel the wave of peristalsis. Only then do they move to the toilet. This preserves the sanctity of the toilet as a place of immediate action, retraining the brain to expect success rather than stagnation. The rocking motion often favored in this position, rolling gently from side to side or forward and backward while hugging the knees, adds another layer of efficacy. This rocking acts as a vestibular trigger. The vestibular system, which controls balance, is linked to the gut. Motion sickness, nausea, is proof of this link. Conversely, gentle,
Rhythmic rocking can soothe the gut. It also physically jostles the abdominal contents. If a stool is impacted or stuck around a sharp corner of the colon, the flexures, the combination of compression and rocking can dislodge it. It is the human equivalent of shaking a ketchup bottle, but with far more biomechanical sophistication. In the context of the top 10, entry number 9 is the outlier because it requires leaving the toilet. It challenges the spatial definition of the bathroom. It suggests that our bathrooms are too small and too cluttered. To perform a deep squat or a floor-based knee hug, one needs floor space, a landing zone for pre-evacuation stretching. Modern architecture, which often crams a toilet into a tiny water closet, is hostile to this practice. A constipation-friendly bathroom would look more like a yoga studio, with a designated mat or open area for this essential preparatory work. Furthermore, for the elderly or those with limited mobility who cannot perform a deep floor squat, the hug your knees maneuver can be modified. It can be done lying in bed, bringing knees to chest immediately upon waking. This bed-based defecation prep utilizes the orthocolic reflex, the spike in colonic motility that occurs when we wake up. By combining the morning wake-up with the knee hug compression, the user maximizes the body's natural morning rhythm. It is a way of priming the pump before gravity even enters the equation. Ultimately, Hug Your Knees is a lesson in compression mechanics. It teaches us that the abdomen is not a static void, but a pliable container that can be manipulated. By folding the body in half, we reduce the volume of the container, thereby increasing the pressure within it. It is simple physics applied to complex biology. It is the ultimate squeeze, a maneuver that proves that sometimes to let something go, you first have to hold yourself tight. It reclaims the floor, the squat, and the fetal tuck as essential tools in the digestive arsenal, reminding us that the journey to the toilet begins with the geometry of the body itself.
10. Short try and rest cycles, no forcing, the chronometry of the colon, and the 3-minute rule. The final entry in our investigation is not a position of the limbs, but a position of time. It is a protocol of duration. Entry number 10, short try and rest cycles, is the most critical behavioral intervention in the management of constipation and the prevention of anorectal disease. It addresses the toilet trap, the modern phenomenon of the marathon bathroom session. In an era of smartphones, heated seats, and bathroom libraries, the toilet has transformed from a functional disposal site into a sanctuary of leisure. This transformation has been catastrophic for human health. The try and rest method argues for a strict militaristic adherence to short time limits. Sit for 2 to 3 minutes, and if evacuation does not occur, stand up and leave. This entry deep dives into the pathology of loitering, the physics of venous engorgement, and the psychological necessity of walking away from an unfinished job. To understand why trying for too long is dangerous, we must examine the anatomy of the anal cushions. The anal canal is lined with vascular tissue known as the corpus cavernosum recti. These are cushions of blood vessels that help maintain a watertight seal, continence. When we sit on a toilet, specifically a toilet with an open hole in the center, the perineum is unsupported. Gravity pulls these vascular cushions downward. Simultaneously, the rim of the toilet seat acts as a tourniquet on the buttocks and thighs, restricting venous return. Blood flows into the pelvis but struggles to flow out. The result is venous pooling. The hemorrhoidal veins swell and engorge, similar to a balloon filling with water. If you sit for 5 minutes, they swell a little. If you sit for 20 minutes, they swell massively. If you then strain against these swollen veins, you risk rupturing them or causing them to prolapse, fall out of the anus. This is the genesis of symptomatic hemorrhoids. The modern epidemic of hemorrhoids is largely a self-inflicted wound caused by their reading on the toilet habit. The short cycle protocol interrupts this pathology. By limiting the sit time to 3 minutes, the user prevents the vascular cushions from reaching that critical state of engorgement. Standing up restores the support to the perineum. The gluteal muscles contract, pumping the pooled blood back into circulation.
Gravity is no longer pulling the rectum out of the body. Instead, the pelvic floor muscles lift the organs back into place. Standing is the reset button for pelvic circulation. Therefore, the instruction no forcing is not just about comfort, it is about structural preservation. The rule is absolute. If the train hasn't left the station in 3 minutes, the station is closed. This approach also combats
combats the neurological condition known as pudendal neuropathy. The pudendal nerve is the primary nerve of the pelvis. It runs through the Alcock's canal and can be compressed by the ischial tuberosities, sit bones, when sitting on a hard surface like a toilet seat. Prolonged compression can lead to numbness, pain, and eventually a loss of sensation in the rectum. This creates a vicious cycle. The user sits longer to try to poop, the nerve gets compressed, the sensation of the urge is dulled, so they sit even longer. Short try and rest cycles prevent this nerve damage. By standing up and walking away, the user decompresses the nerve, preserving the sensitivity required to feel the next urge. The rest phase of the cycle is just as important as the try phase. When the user stands up and leaves the bathroom, they are not giving up, they are engaging in active waiting. Walking is a powerful pro-motility agent. The rhythmic impact of the feet on the ground and the rotation of the torso stimulate the colon. It is often the act of giving up and walking to the kitchen that triggers the movement that the 20 minutes of straining could not. This is the law of reversed effort. The harder you try to force a bowel movement, the more the sympathetic nervous system stress tightens the sphincter. When you walk away, you distract the brain, the stress drops, and the parasympathetic system, release, can finally engage. The rest cycle is a psychological trick to lower the stakes. This method also addresses the sunk cost fallacy that plagues constipated individuals. A person sits for 10 minutes and thinks, I've already invested this much time. If I leave now, it was a waste. I'll just stay 5 more minutes. This thinking leads to 30-minute sessions of fruitless straining. The short cycle protocol reframes the goal. The goal is not to poop at all costs. The goal is to check if the body is ready. It turns the bathroom visit into a reconnaissance mission rather than a siege. If the body says no within 3 minutes,
the user respects that answer and retreats, promising to return later. This builds a relationship of trust with the body, rather than one of coercion. The implementation of this technique requires a radical change in bathroom architecture, specifically the removal of distractions. The short cycle demands that the bathroom be a boring place. No magazines, no books, and absolutely no phones. The smartphone is the greatest enabler of constipation in history. It disassociates the user from the passage of time. A 3-minute scroll on social media feels like 30 seconds, but the rectum feels the full 3 minutes of gravity. By banning devices, the user becomes acutely aware of the reality of the situation. If you are just sitting in a small tiled room staring at a door for 3 minutes with nothing happening, you will naturally want to leave. Boredom is the ally of bowel health. It encourages the get-in, get-out mentality that protects the pelvic floor. For those with slow transit constipation, where the bowel moves very slowly, the try and rest cycle is a way to manage the day without becoming an invalid. These individuals can spend hours on the toilet if they let themselves. This destroys their quality of life. Breaking the day into attempts allows them to live their life in between. It suggests a schedule. Try upon waking, cycle 1. Eat breakfast, walk around. Try again 30 minutes later, cycle 2. Go to work. This scheduling utilizes the gastrocolic reflex windows without holding the person hostage in the bathroom. It professionalizes the process. Furthermore, this entry touches on the concept of rectal compliance. The rectum is a storage tank that can stretch. If we ignore an urge, the rectum stretches to accommodate the stool and the urge fades. This is a survival mechanism. However, if we sit and strain when there is no urge, we are confusing the sensors. We are trying to push against a door that isn't unlocked. The try and rest cycle reinforces the connection between urge and action. It trains the user to only sit when the signal is strong. If the signal fades, stand up. Do not chase the signal into the abyss of straining. Retaining the sensitivity of the rectal stretch receptors is crucial for long-term continence and regularity. The cultural shift required here is immense. We treat the bathroom as a place to hide. From our kids, our bosses, our spouses, it is the last lockable refuge of the modern human.
To adopt the short cycle is to lose that refuge. It forces us to find relaxation elsewhere. But the medical verdict is clear. The toilet is an ergonomic disaster zone designed for a singular, rapid biological function. It is not a recliner. Using it as one invites a host of pathologies, from fissures to prolapse. In conclusion, entry number 10 is the governance layer of the top 10. You can have the perfect squat, entry number 1, the ideal footstool, entry number 2, and the best breathing technique, entry number 4. But if you vince the element of time, you will still damage your body. Short try and rest cycles impose a discipline on the act. It teaches us that defecation is a reflex, not a project. You cannot force a reflex. You can only create the conditions for it and wait for it to arrive. If it doesn't arrive, you stand up, you walk away, and you live to poop another day. It is the ultimate act of mercy for the besieged modern pelvis, the permission to stop trying.